Optics and refraction. First we'll discuss about refractive index of different medium. Air it is 1, then cornea 1.376, cornea is 1.376, then aqueous and vitreous both are 1.336, and lens cortex it is 1.39, and lens nucleus it is 1.41, that is the highest. Lens nucleus is 1.41, which is the highest, and vitreous again and aqueous both are 1.336. Next is coming to few cardinal data of lens. Principal axis is the line joining centers of curvature of its surface. Then optical center is the middle point of biconvex lens. Point of biconvex lens. Principal focus is the point on the principal axis. Here there is a point on the principal axis where parallel rays of light after passing through the lens. In convex lens it will converge, and in diverging lens it will diverge. That is our principal focus. Next is focal length. It is the distance between optical center and principal focus. Distance between optical center and principal focus, that is a focal length. Power of a lens is ability of a lens to converge a beam of light falling on it. Ability of lens to converge beam of light falling on it. Power is equal to 1 by focal length. So this is the principal axis, the line joining the center of curvature of its surface. Then we have the optical center, that is the middle point of the biconvex lens, and we have the principal focus, that is a point on the principal axis where parallel rays of light after passing through the lens converge. In convex lens it will converge or appear to diverge in diverging lens. That is principal focus. Focal length is the distance between the optical center and the principal focus, that is a focal length. Then power of a lens is ability of the lens to converge a beam of light or falling on it. Power is equal to 1 by focal length. Now schematic. Next is schematic diagram as described by Goldstrand. Here dioptric power is plus 58 diopter, that is cornea 43 diopter and lens 15 diopters. Here cornea, here we have two nodal points on the posterior surface of the lens. According to Goldstrand, there is two nodal point on posterior part of lens. Next is listing and Donder's reduced eye. Here total dioptric power is plus 60. Power is plus 60 diopter, cornea is 43 diopter, and lens is plus 17 diopter. Lens is 17 diopter. In Goldstrand it is 58 diopter, whereas in listings and Donder's reduced eye it is 60 diopters. Okay, the total dioptric power. Here in listing and Donder's eye, principal point P lies 1.5 mm behind anterior surface of cornea. And the nodal point N lies behind 7.2 mm behind anterior surface of cornea, that is on the posterior part of crystalline lens. This nodal point lies 7.2 mm behind anterior surface of cornea, that is posterior part of crystalline lens. Here the nodal point, the principal point lies 1.5 mm behind the anterior surface of the cornea, and nodal point lies 7.2 mm behind the anterior surface of cornea, that is on the posterior part of the crystalline lens in listing and Donder's eye. Next, coming to axis of eye, optic axis is a line passing through the center of curvature of cornea, and center of curvature of anterior and posterior surface of lens. This is a optical axis. Here it is a line passing through the center of curvature of the cornea and the center of curvature of the anterior and posterior axis, posterior surface of lens, that is optical axis. Next is pupillary axis. Pupillary line perpendicular to cornea, at the point coinciding to the center of the pupil, that is at the point coinciding to the center of pupil, that is pupillary axis. Next is visual axis. It is a line joining the fixation point nodal point and fovea. Here this is the visual axis. Here it is a point joining the the line joining the visual fixation point, then nodal point and the foveal point, that is the visual axis. Fixation axis is the line joining the fixation point and center of rotation. Fixation axis is the line joining the fixation point and center of rotation. Now coming to next we'll discuss about the visual angles. Visual angle alpha is between the optic axis and the visual axis. AR is the optic axis and OF is the visual axis. Angle alpha is between the optic axis and the visual axis, that is O and A. This is angle alpha. Then angle gamma is between the optic axis and the fixation center at the rotation of the eyeball. This is angle gamma. Here this is angle gamma. And angle kappa is between the visual axis and the pupillary line, that is angle kappa. Angle alpha between optic axis and visual axis. Angle gamma between optic axis and fixation axis at the center of rotation of eyeball. Angle kappa is between the visual axis and the pupillary axis. Positive angle kappa, we see it in pseudo-exotropia. See, when the eye deviates outward, then it appears as the fovea is deviated this side inward, and then we get positive angle kappa. When eye is deviated, apparent deviation, when eye is deviated inward, we get negative angle kappa. Positive angle kappa is seen in pseudo-exotropia and negative angle kappa is seen in pseudo-esotropia. Is coming to few normal mechanism to decrease aberrations in human eye. These are normal mechanism which is present in all human eyes. It includes cutting of peripheral rays of iris, cutting of peripheral rays by the iris, then high refractive index of the core of nucleus of the lens. Of the lens is less than that of the periphery of the lens. Because of the high refractive index of the nucleus, core of nucleus of the lens less than that of the periphery of the lens, that is cortex. Next is low sensitivity to peripheral retina. And last one is Stiles-Crawford effect. Here there is more sensitivity to retina, more sensitivity of the retina to perpendicular rays rather than oblique rays, that is Crowe-Stiles-Crawford effect. To perpendicular rays than oblique rays. These are few normal mechanisms to decrease aberrations in human eye. Stereopsis, it is known as a perception of depth produced by reception in the brain of visual stimuli from both eyes. Next, coming to few refractive errors of refraction. Now there are few terms we should know. Emmetropia is when parallel rays of light coming from infinity is focused at the sensitive layer of the retina when accommodation is at rest. They are focused at the sensitive layer of the retina when accommodation is at rest. That is emmetropia. This is emmetropia when parallel rays of light coming from infinity are focused at the sensitive layer of the retina when accommodation is at rest. Emmetropia is when the parallel rays of light coming from infinity are focused in front or behind the sensitive layer of retina when accommodation is at rest. Emmetropia can be myopia, hypermetropia or astigmatism. Now axial emmetropia is when when there is 1 millimeter elongation of axial length, it causes minus 3 diopter of myopia. Or if there is 1 millimeter shortening of axial length, it causes 3 diopter of hypermetropia. That is axial emmetropia. In curvature emmetropia, if there is 1 millimeter change in radius of curvature of the cornea, it produces a 6 diopter change of refractive change. Steeper, that is more curved the cornea, it produces more myopia, and flatter cornea produces hypermetropia. That is about curvature emmetropia. Next, coming to hypermetropia. Hypermetropia, also known as hyperopia or long-sightedness. Hyperopia or long-sightedness is when the parallel rays coming from infinity are focused behind the retina. Behind the retina when accommodation is at rest. When parallel rays coming from infinity are focused, it is focused behind the retina when accommodation is at rest. Etiology, it can be axial, or the cause can be axial cause, curvatural, index, positional hypometropia. In axial, it is a most common form. The total refractive power is normal, but here the total refractive power is normal, but there is axial shortening of the eyeball. For 1 mm shortening of the anterior posterior diameter, it results in 3 diopters of hypermetropia. Curvatural, next coming to curvatural hypermetropia. Here the curvature of cornea or lens is flatter than normal, resulting in decreased power of the refractive power of the eye. A 1 mm increase in radius of curvature will result in 6 diopters of hypermetropia. Then coming to next is index hypermetropia. In index hypermetropia, it is due to increase in refractive index of the lens in old age. Usually in old age, it can also occur in diabetes. Next is positional hypermetropia. It is due to backward displacement of lens. Next, coming to clinical types of hypermetropia, it can be simple developmental hypermetropia, pathological hypermetropia, or functional hypermetropia. But simple or developmental is in pathological, it can be index hypermetropia, that is due to acquired cortical sclerosis, or positional hypermetropia due to posterior subluxation of lens. Then pathological can be consecutive hypermetropia due to surgically overcorrected myopia, or axial hypermetropia due to forward displacement of retina, as in case of retinal detachment or central serous retinopathy. Next is curvatural hypermetropia due to traumatic or post-inflammatory corneal flattening. It can occur. These are the pathological hypermetropia. Pathological hypermetropia can be index, positional, consecutive, axial, curvatural. Next, coming to functional hypermetropia, it is due to the paralysis of accommodation. It can be either due to a third nerve palsy or internal ophthalmoplegia. That is functional hypermetropia. Next is components of hypermetropia. Total hypermetropia is a latent plus manifest. Manifest hypermetropia include facultative and absolute. Total hypermetropia is the total refractive error that is estimated after cycloplegia with atropine. That is total hypermetropia, total refractive error. There are two components in total hypermetropia, that is latent hypermetropia and manifest. Latent hypermetropia is hypermetropia of about 1 diopter, which is normally corrected by the inherent tone of ciliary muscle. It is high in children and it gradually decreases with age. Manifest hypermetropia is that cannot be corrected by the ciliary muscle tone. It can be facultative or absolute. Facultative is overcome by effort of accommodation. Absolute is cannot be overcome by effort of accommodation. That is absolute. Coming to clinical features of hypermetropia, there can be asthenopic symptoms. That is when hypermetropia is fully corrected by sustained accommodation. When the patient uses whole the accommodation to correct hypermetropia, will get asthenopic symptoms. That is tiredness of eyes, frontal headache, watering, and mild photophobia. It is associated with new work and patient will increases towards the evening. Patient will complain of increased asthenopic symptoms towards evening. Next is defective vision. That is when hypermetropia is not corrected by accommodation. That is the patient will have defective vision. Other features include small size of eyeball and cornea, so that the rays will come and rays light coming from infinity are focused behind the retina because of small size of eyeball and cornea. Then there will be patient can complain of shallow AC. On fundus examination, patient can have a small optic disc, more vascular, and pseudopapillitis will be there, that is ill-defined margins, and shining retina, that is also known as short silk appearance. Here you can see the margins are ill-defined, and there is a fundus picture in hypermetropia, small ill-defined margin and shiny retina, that is short silk appearance, and vessel reflexes are accentuated. Again, same thing, small disc, clearly defined margin stimulates papillitis. In A scan, there is short anterior posterior diameter in axial hypermetropia. In axial hypermetropia, grading of hypermetropia, it is graded as low when the power is less than 2 diopters, moderate when it is between 2 to 5, and high when the power is more than 5 diopters. That is a grading of hypermetropia. Coming to complications of hypermetropia, it include recurrent stye, blepharitis, chalazion, accommodative convergent squint, especially in children between 2 to 3 years, amblyopia, and can predispose to primary narrow open angle glaucoma. Optical treatment include convex lenses. Surgical treatment include hyperopic LASIK. It is effective in correcting up to +4 diopter. And then other treatments include hyperopic photorefractive keratoplasty, thalmium, holmium, chromium YAG laser, and conductive keratoplasty. These are the cornea-based procedures. Now coming to lens-based procedures, there can be phakic refractive lenses or implantable contact lenses for hyperopia of +4 to +10 diopters. Refractive lens exchange can be done for high hypermetropia, especially in presbyopes. Now hypermetropia in newborn is due to short anterior posterior diameter. In old age, it is due to changes in the crystalline lens. Next, coming to myopia. Myopia is also known as short-sightedness. That is when parallel rays of light coming from infinity are focused in front of the retina. And when here also again accommodation is at rest. Grading myopia is graded as low when power is less than 3 diopters, moderate when the power is 3 to 6 diopters, and high when the power is more than 6 diopters. Congenital myopia is present since birth. Now myopia can be congenital myopia, symbol or developmental myopia. Congenital myopia is present since birth. It is mostly unilateral and the error is usually 8 to 10 diopters, which remains constant. Next is the child who is having congenital myopia can develop convergent squint. Next is symbol or developmental school myopia. It is the most common variety. Prevalence is 20 to 40%. Sharpest rise occurs at the school going age, that is 8 to 12 years, and also known as school myopia. 20% of children have both parents myopic. Symptoms include poor vision of distance, asthenopic symptoms, and half shutting of eyelids. Signs include prominent eyeball, anterior chamber slightly deep, large pupil, and fundus is usually normal in symbol or developmental myopia. It occurs between 5 to 10 years and keeps on increasing till 20 years and do not exceed beyond -6 diopters. That is symbol myopia. Next, coming to pathological or degenerative or progressive myopia. Here the prevalence is approximately 2% and it starts at 5 to 10 years. And more rapidly progress to hype myopia with degenerative changes in early life. Here heredity plays a major role. Symptoms include defective vision, musca volitans. Musca volitans is nothing but floating black opacities. These floating black opacities are musca volitans. Then night blindness. These are the symptoms in degenerative myopia. Signs include prominent eyeball. It can be seen as pseudoproptosis. It appears as pseudoproptosis, prominent eyeballs. Large cornea, deep anterior chamber, and exophoria, or even a manifest divergent squints can be seen. Here we can see the large cornea, deep anterior chamber, and sometimes even a manifest divergent squint can be seen. Fundus in pathological myopia, there is a large and pale optic disc, and temporal edge shows a characteristic this myopic crescent in temporal edge. Sometimes a peripapillary crescent is also seen. Temporal edge, there is characteristic myopic crescent. Sometimes peripapillary crescent is also seen. Foster Fuchs spots are seen at macula due to subretinal neovascularization and choroidal hemorrhage. We can see Foster Fuchs spots. And sister degeneration at the periphery of the retina can also be seen. Sister degeneration at the periphery of the retina and posterior staphyloma is also seen. Vitreous, there is vitreous liquefaction and opacities. And posterior vitreous detachment, there is we can see the V's reflex, which has been discussed in retinal literature. And contracted visual fields can be seen, and subnormal ERG is also seen. in severe cases, pathological myopia, there will be contracted visual field and ERG will be subnormal. Complications include retinal detachment, complicated cataract, vitreous and choroidal hemorrhage. Strabismus fixus convergence, that is convergent squint can be seen in severe cases. In index myopia is a premonitory symptom of senile cataract when it is due to increased refractive index of the nucleus of the lens. Treatment is concave lens, usually undercorrected to avoid problem of neovision and minification of images. It is usually undercorrected. Low vision aids in patients with progressive myopia and degenerative changes. Surgery, it can be lens-based procedures include Ficala's clear lens extraction when it is more than 15 diopters, phakic refractive lens in case of implantable contact lenses, refractive lens exchange, removal of lens by ECC with the IOL implantation of more than 12 if it is more than 12 diopters. Now, orthokeratology is a term. It is a non-surgical reversible method, reversible molding of cornea with overnight wearing unique rigid gas permeable contact lens. Here we can correct up to -5 diopters and can be used below the age of 18 years of age. Here we mold the cornea. Overnight molding of the cornea is done by wearing the rigid gas permeable contact lens. Next, coming to cornea based procedures. Here we can do radial keratotomy. No, it is usually not done nowadays. We make this radial incisions in the cornea and heal by flattening of the cornea. Radial keratotomy not done nowadays. Photorefractive keratotomy is done. It is also not preferred nowadays. Intracorneal ring implantation, which is a reversible technique, is done. Excimer laser assisted in situ keratomylasis, that is LASIK. It can correct myopia of up to 12 diopters and hypermetropia of up to 4 diopters and astigmatism up to 5 diopters. Indications for LASIK include the patient should be more than 20 years and stable refraction for at least 12 months and absence of any corneal pathology. Contraindications is when the corneal thickness is less than 450 micrometers. It is an absolute contraindication. Or ectasia, keratoconus, endothelial cell count less than 1500, diabetic retinopathy, single eye and glaucoma. Advantages of LASIK include pain, minimal or no postoperative pain. Then early recovery of vision, no risk of perforation during surgery, no risk of globe rupture during surgery, no residual haze. Disadvantage of LASIK include it is expensive, it requires greater skill and greater surgical skill. Then there can be flap related complication like intraoperative flap amputation, wrinkling of flap on repositioning, or dislocation or subluxation of the postoperative flap, or epithelialization of flap bed interface, or irregular astigmatism can occur. These are the disadvantages of LASIK. Next is aphakia. Aphakia is when there is defined when there is absence of crystalline lens. The patient will become highly hypermetropic eye. Total power is reduced from +44 to +44 diopter from +60 diopters. There is total loss of accommodation in case of aphakia because of the loss of crystalline lens. Clinical features include diminution of both neovision and far vision. The patient can complain of erythropsia and synopsia, that is seeing red and blue images due to excessive entry of infrared and UV rays because of absence of crystalline lens. The anterior chamber can be deep. There is iridodonosis, that is tremulescence of iris, and patient can have jet black pupil. And there is only 2 images, Purkinje images. Purkinje images only 2 are there instead of normally there are 4. Difficulties of aphakia and its correction by spectacles. When aphakia is corrected by spectacles, the patient will have image magnification of about 25 to 30%. And their spherical aberration produce something known as pin cushion effect. Here you can see the pin cushion effect. This is a normal undistorted square pattern. In pin cushion effect, the image magnification increases with distance from the optical axis. So here the visible effect is that lines that do not go through the center of the image are bowed inwards. The lines that do not go through the center of the image are bowed inwards towards the center of the image like a pin cushion. Then there is something known as Jack-in-box phenomena. Here it is a ring scotoma moves in opposite direction as the head moves, as the opposite direction of the eye movement. When the patient moves towards A, the ring scotoma moves towards B. It is produced from the prismatic effect from the edges of the spectacles. It is also known as roving eye ring scotoma. Then the patient can the prismatic errors resulting from displaced optical centers of the lens, and the patient can have reduced visual fields and poor eccentric acuity. Next, coming to astigmatism, it is a type of refractive error wherein the refraction varies in different meridian of the eye. First is regular astigmatism. It is when the refractive error change uniformly from one meridian to another. With the rule, it can be either with the rule astigmatism or against the rule astigmatism, oblique or bioblique. With the rule astigmatism is when the two principal meridia are placed at right angle. Vertical meridian, with the rule, the vertical meridian is more curved than the horizontal. Against the rule astigmatism, here the horizontal meridian is more curved than the vertical. In oblique astigmatism, the two principal meridia are not horizontal or vertical, but though these are at right angles, to one another. That is oblique astigmatism. In bioblique astigmatism, the two principal meridia are not right angle to each other. The configuration of focal lines. Next is Stump's conoid. Stump's conoid is a configuration of rays refracted through an astigmatic, that is toric surface, is known as Stump's conoid. Configuration of rays refracted through an astigmatic surface, that is also known as toric surface. And the distance between the two focal lines, this focal line is known as the focal interval of Stump. Distance between the two focal lines is known as the focal interval of Stump. Now, symptoms of asthenopia includes symptoms of astigmatism include asthenopia, decreased visual acuity, blurred and defective vision, elongation of objects. The patient will keeping the reading material close to the eyes as possible. Signs include half closure of the lid, head tilt, oval or tilted optic disc in astigmatism. Investigation include retinoscopy, keratoscopy, astigmatic fan test or Jackson's cross cylinder test. Treatment is cylindrical lens is given to the patient in astigmatism. Surgery includes astigmatic keratotomy, photoastigmatic refractive keratotomy, that is PRK, or LASIK is done. Lenses, we can give rigid contact lenses, toric contact lenses, or toric phakic IOLs can also be given. Anisometropia, next coming to anisometropia, it is defined when the total refraction of the two eyes is unequal. Refraction of the two eyes is unequal. Anisometropia 5%, that is 2.5 diopter, is well tolerated. Anisoconia is when the image projected to the visual cortex from the retina are too abnormally unequal in size or shape. Here up to 5% is well tolerated. Now next is neoreflex. Neoreflex, it has two components, that is convergent reflex and accommodation reflex. Convergent reflex is contraction of pupil on convergence. Accommodation is contraction of pupil associated with accommodation. Next coming to accommodation. Next is accommodation. Accommodation is a mechanism by which we can focus the diverging rays from near object onto the retina. This is an accommodative lens. At rest, the radius of curvature of anterior surface of lens is 10 mm and the radius of curvature of posterior surface of lens is 6 mm. Now, during accommodation, the curvature of posterior surface of lens remains constant, but the anterior surface can changes. Now, in strong accommodation, the radius of anterior surface of lens can anterior surface also become 6 mm. Okay. Then during accommodation, posterior surface of lens remain unchanged. It will remain the same. During accommodation, curvature of the posterior surface remains constant, but the anterior surface changes. In strong accommodation, radius of curvature of anterior surface of lens also becomes 6 mm. Now, there are certain terminologies like a near point or punctum proximum. Near point is the nearest point, as the name indicates, the nearest point at which small objects can be seen clearly. nearest point at which small objects can be seen clearly. Far point or punctum remotum is the farthest point at which the small objects can be seen clearly. Range of accommodation is the distance between this near point, distance between this near point and far point. Distance between near point and far point, that is range of accommodation. Amplitude of accommodation is the difference in the dioptric power needed to focus at near point and far point, that is amplitude of accommodation. In emetropic eye, far point is emetropic eye, far point is at infinity, and near point at 10 years it is at 77 centimeters, and 40 years it will come to 25 centimeters, and 45 years it will come to 33 centimeters. That is in emetropic eye. Now next is coming to presbyopia. We'll discuss about presbyopia is nothing but the physiological insufficiency of accommodation leading to progressive fall in near vision in old age. The causes can be decreased elasticity of lens capsule, increased size and hardness of lens substance, that is sclerosis, basically sclerosis of the lens, and age-related decline in ciliary muscle power. Causes of premature presbyopia include uncorrected hypermetropia, premature sclerosis of crystalline lens, premature sclerosis of the crystalline lens, and general debility causing presenile weakness of ciliary muscle. Or chronic simple glaucoma can also cause premature presbyopia. Management include prescription of appropriate convex glass for near work. Surgery, we can do monovision LASIK and presbyopic bifocal LASIK. Next, coming to contact lens. Contact lens can be hard, rigid gas permeable, or soft lenses. Hard, it is made of PMMA, polymethyl methacrylate. There is poor oxygen delivery. Rigid gas permeable, it is a copolymer of PMMA and silicon containing cellulose acetate butyrate. The soft contact lens is made up of hydroxymethyl acrylate. It contains 79% of water. Hard, there is poor oxygen delivery. RGP, there is moderate to high oxygen delivery. And soft, there is high oxygen delivery. Next, coming to visual acuity, the hard has good visual acuity, good visual clarity. RGP has clear vision, whereas soft, it need to refocus after a blink. After every blink, we have to refocus. Hard contact lens can be used in astigmatism. RGP can also be used in astigmatism, whereas soft contact lens is less suitable in astigmatism. RGP can be used in astigmatism. Hard lenses may scratch. RGP do not scratch or tear. Soft lens tend to tear. Hard lens, few deposits will be seen. RGP also few deposits might be seen. Soft lenses deposit accumulate over time. Tinted contact lenses are used in albinism, that is to relieve photophobia. Absolute indication for contact lens use include anisometropia, unilateral aphakia, high myopia, keratoconus and irregular astigmatism. These are absolute indication for contact lens use.